very much. It's good to be here and be involved in this very interesting group and this workshop. So I'm going to present, basically in a short presentation, and instead of giving very specific ways on how to analyze the data, I would like to basically offer some questions and how to address those questions when we are doing looking at the analysis. So the 5 things I put over there is that why is the context important, and what should be the outcomes, which designs should one use, and which analytical methods should one use, and then when should the analysis actually happen. So why is context important? Because contextual factors can influence the implementation, and these may also change over time, producing unpredictable effects that requires continuous adaptation by implementers. And because our programs and interventions are not context free, and there are lots of constraints that could be policy, system, service constraints, socio-cultural or other, even technical constraints, which may be there. Sanjay showed the TDR toolkit in his presentation in one of the slides. And I took this picture from that toolkit, but basically describes the physical, socio-economical, and cultural context, because these comprise of various stakeholders and their interactions, the demographic and epidemiological conditions, the structure of health systems, role played by governments, non-government organizations, other providers, citizens, community. And as you can see here on this diagram, you can see various components mentioned here, from political, cultural, socioeconomic stakeholders, health systems, and each one of them has some elements that can affect the implementation of your research project. So it's important to actually look into these things before actually designing and your studies, and also while you're designing it to basically find out which areas would potentially affect your research project. This diagram also shows, elements of a typical health system. So sometimes people think the health system is only what the government has put in place. But if you look at a typical health system, it's made up of actually multiple subsystems. The primary focus of all of them is that somehow health is promoted or restored or maintained. But each group within this diagram, if you looks at these things differently. Now, WHO has identified 6 key groups or building blocks which make up the health systems, like leadership, governance, healthcare financing, health workforce, medical products, technologies, and information and research. And these blocks address access to and coverage of health services, as well as quality and safety of services. But other factors, such as human beings who are recipients of the health system, community care, they also contribute to health systems. And for each component relevant to an implementation research project, it is helpful to undertake a systematic descriptive analysis to help identify the relevant decision-making agents and the formal and informal institutions that govern its operation. So Dipti mentioned the PSBI. For example, I'll use that example in several places now. Just to briefly tell you a little bit about it, there are 2 groups within this group who are today involved, the Pune group with Sudhupti Sanjay, and the SAS group who have done this, this study in India. Basically, WHO did this work in 7 different countries, 4 countries in Africa and 3 in Asia. And the idea was that sick young infants who are suspected sepsis or possible bacterial infection, most of these young infants do not get to health facilities or hospitals where they should be treated. The WHO developed a guideline in 2015 on how to manage these children when referral was not possible. So this implementation research was done in these 7 countries in 13 different sites to look at how we could implement this in a way that the coverage could increase and whether it was feasible to implement this guideline. So if you look at this, the system which you are looking at, this figure now, so each of these 7 countries had a different way of looking at these things. The African countries, have a different level of health system to look at these this intervention, whereas the India, you are well aware of that you have a community where you have ASHA workers, and there is sub-center, now it is called Family Health Care Center, I think. And then you have a community health center, and then you have, before that, you have a primary health center and sub-district hospitals and district hospitals, etc. But you have different states, and each state has looked at it in a different way. The study was done in 4 states in India, and including Maharashtra. So Pune, Haryana, Himachal Pradesh, and also Lucknow. But in each of these states, their intervention was done in a little different way. So that is why this context is extremely important, and it plays an important role. The other important element of this is the users of the research. That who are these people who use the research? Because implementation research is basically not that we are trying to see whether this intervention is effective, but we are trying to see whether effective intervention can reach to a large number of people who need it. So a lot of different players are involved in this. And when we were setting up this possible serious bacterial infection studies, implementation research studies in different countries, so we had to first hold policy dialogues at national or central level, and then including the different states or provinces which were involved, the regions that were involved, then went down to the places where the actual studies were going to be done. So this is basically, the users may include executive decision makers at central ministry level, seeking advice for specific decisions, policymakers at state level or central level who need to be informed about particular programs, managers at teams at district level who are using quality improvement strategies or other things. And then you have practitioners at the health centers or a private sector who need to be convinced to use the interventions that are based on evidence. And then people in the community and people who are influenced to change their behavior, to have a healthier life, or communities who are involved in the research and taking action to improve their conditions. Like, for example, here in this PSBI implementation research, we wanted people to go to the hospitals when their young infants were sick. Most of them refused, except in Pune, where many of them accepted referral. Only 5% refused referral, but in other places within India, some 80% refused referral to go to the hospital. So each place had different way of looking at things. And then we had to convince them, okay, if you can't go to the hospital, can you go to the health center? And then whether you can be managed at that health centers or not. So when the design and conduct of the study is being done, so all these players have to be involved in order to have a better collaboration and also partnership. So in each of these places where we set up this PSBI implementation research, there were 2 components. One was the research group, but other was the implementation group, which consisted of the health managers and your chief medical officers, the block medical officers, and the medical officers working at the primary healthcare center or in the community healthcare centers, etc. So most of the research projects involve users when the dissemination of the results come in. But here, the dissemination of the results doesn't really mean that when the study is finished, only then the results will be disseminated, although that is also something which is needed. But here, you continuously talk and communicate with these people who are actually implementing the intervention. And the research group looks at various things to see and then communicates to the implementation group that, okay, here are some things which you can use. So I'll come to that more when I'm discussing the implementation research outcomes. But this is a very important piece that somebody asked yesterday, Rajiv, whether the ministry people should be involved, whether the health department people should be involved. From our point of view, if you are trying to implement a known intervention, you cannot do without the involvement of implementers. They are the ones who are actually in the system. The researchers are mostly outside the system. So until and unless both these groups are working hand in hand and together, it's very difficult to actually do good implementation research which would have an impact. You may be able to do something, but that would be done as a project and not really help the actual implementers who need this information which you're trying to provide them. So what should be the outcomes? Most research projects have outcomes like, okay, this intervention is effective. But here we are talking about how to scale up a sort of effective intervention. So the primary focus is on indicators of success of implementation. And these outcomes should be basically describe the intentional actions to deliver services. They all serve as indicators of the success of implementation. And implementation research uses these variables to assess how well the implementation has occurred, or to provide insights about how this contributes to one's health or other important health outcomes. So I'll go over one by one some of the outcomes which have been listed to look at the implementation by a paper by David Peters, which was published in BMJ 2013. So you look at acceptability, that the intervention which you are trying to scale up, what is their perception of stakeholders, which includes both consumers and providers, managers and policymakers, etc. And because until unless they have, they accept the intervention, it's very difficult to implement it or scale it up. And whether they adopt it and the actual intention or action to basically try to, and this also includes uptake of intervention by the consumers and utilization of the intervention. If people do not come to the health facility where you have the intervention, then basically your utilization of the intervention is low. And you can't wait till end of the research project to see whether this is happening or not. So this has to be done while the project is ongoing, and this has to be analyzed and then acted upon so that you can improve the implementation. Then you look at also the appropriateness, whether the intervention which you have, it fits or is relevant to a particular setting or particular target audience or not. And this also then is related to, in a way, feasibility, the extent to which an intervention can be carried out in a particular setting or an organization, and whether it is practically fit or not fit. Like, for example, I was talking about the PSBI. Now, in DRC, where we set up this thing, the health center was on an average 1 kilometer to 7 kilometers from a community. And the transport system is hardly there. In India, you have, a huge number of private providers and rickshaws and other things available. So what we had to do there was that if a child needed a referral to a health facility and the family was unable to walk, then the community health worker would put the child and the mother on his cycle and then basically ride them to the health center in order for them to be actually seen by a health nurse. So these are some of the practical things and things which you have to, you only do that when you are actually working together with the system and looking at the particular challenges and constraints which are available in each of these settings. And without that, it becomes extremely difficult. In India, if you compare the thing which was done in Pune and the thing which was done in Lucknow, it was quite different. In Pune, 5% of the families did not accept referral to a hospital. Whereas in India, in Lucknow, more than 80% of the families did not accept referral to a hospital. And there were 255 families in Lucknow who did not want to go to any public sector place. So the intervention which we were introducing was in the public sector place, but those families did not want to go there. And out of those 255 who basically went to either private sector or some informal provider, etc., 96 infants died. Whereas, in Pune, the death was only 6 deaths out of 175 cases. So these things need to be addressed while these studies are ongoing in order to improve things. And some places you can improve the implementation, and in others it is difficult. Like for example, in Lucknow, there was a problem that when the patient reached the hospital, there wouldn't be any bed. And then sometimes the patient family had to take a patient from one hospital to another hospital to another hospital. And they found that, even though the family reached the hospital, but they were not able to get the appropriate treatment because the feasibility of the system did not allow the beds, and they were, sometimes not managed in the most effective way. So then we have other implementation outcomes like coverage. Now, in India, in 2014, the government of India decided that when a sick young infant cannot be referred to a hospital, the A&M would manage that young infant at a subcenter with injection gentamicin and oral amoxicillin under 2 months old. Now, this guideline was produced in 2014, but nobody really took up the guideline. None of the A&Ms were managing any of the young infants in the subcenters. They were afraid. They had not really managed any sick young infant before. Even the doctors in the PHCs and CHCs were not managing sick young infants. So how could A&M manage a sick young infant at that center? When we started this PSBI implementation research projects, even the doctors at the PHCs and CHCs had to be technically supported, handheld and mentoring, etc., to give them confidence that they could manage these sick children at that level of facility. So in order to increase coverage. So while the government of India did a good thing by producing a guideline, but the coverage of that intervention was hardly there. Whereas after introducing this implementation research, the coverage increased in different places, although not through subcenters, because A&Ms still were not very comfortable. And only after, a year and a half of implementation at various sites, in some places, A&M started to manage these young sex young infants at sub-centers, like in Himachal Pradesh. Maybe I think 2 or 3 A&Ms at the end of the project were able to manage sex young infants at their facilities, which was a sub-center. Normally, most of them would go to a PHC or a CSC. So the coverage is extremely important, whether your reach and access of this intervention is there, and that you can look at while the intervention is ongoing and implementation is being conducted. The quality is extremely important of the intervention that you are trying to implement, and the fidelity. It's not like, for example, in this PSBI intervention, that when you had to refer a child to a hospital, you had to give them pre-referral antibiotics, one. Secondly, there were subcategories of PSBI. Some of them needed immediate referral, and some of them could be treated in an outpatient facility, and some of them could be treated at home. But many a times you would find that your health workers were not following these guidelines. So they had to be then communicated with, and refresher trainings were held and other things, so that they would follow the actual guideline which was being implemented by the government of India. So adherence and delivery as intended, integrity, these are very important aspects of various interventions and the implementation that one is trying to promote. And you'll listen more about it, I think, from Sharmila also, about when they were doing the KMC projects. Governments are always interested in how much would it cost. Yadib also mentioned yesterday about the total cost, and so there are different things related to cost. Some people look at cost effectiveness and cost benefit, etc. But the government's basic idea is budget. How much money would be needed to scale up this intervention? So that is important to have this kind of information available for helping governments to make decisions for scalability and also for sustainability of the intervention. Because if we do not providing enough resources, both financial and technical, the sustainability of any intervention is quite difficult. So in order to continue an intervention in a good quality fashion and integrating it into the system, you need both financial and human technical resources also. Now, apart from this implementation outcomes, obviously health outcomes, because if you're talking about health intervention, health outcomes, but those mostly come at the end of the research project, like disease outcomes, morbidity, mortality, adherence, and depending upon what kind of research project are you doing. For vaccines, you want to see, what was the acceptance of vaccines and other things. So those things obviously are there, but from implementation research point of view, these are ultimate outcomes for that project, but they have a kind of secondary focus, and during the project, the implementation outcomes are actually much more important. So which design should one use? Both Sanjay and Suduptu did a very fine presentation of sharing with you a huge number of designs. Sometimes is overwhelming also. So if I were to look at these designs, that if yesterday Rajiv shared a definition which said that if you want to improve the implementation of an effective intervention such as KMC or PSBI through implementation research, which will be useful for the program, is it necessary to have a control or comparison group? People are very fond of having randomized controlled trials and comparing. So if you have already a proven effective intervention like KMC or like possible CS bacterial infection, then basically there is no need for having a comparative group when you're trying to scale up that intervention. So the potential common designs for these kind of things, you've heard a lot of these definitions a little bit earlier, but some of these things which I mentioned here are more commonly used designs in the implementation research and before, after, time series quality improvement ones, the ones which were actually used much more often than the other ones. Now, which analytical methods should one use? Obviously, it depends upon the type of research and also the type of design that you have. And I cannot really go over each of these designs separately. But from our point of view, a mixed method which includes both qualitative and quantitative data is needed for most implementation research projects. Because when you are actually implementing the project, you need to look at participants, and you need to, in the field, you need to observe things. You need to review the documents of, say, if it was a disease, then management of how the management is going on. You need to conduct in-depth interviews with consumers and also providers, and focus group discussions, and sometimes videos, films, and photos can help. So there is a need for having this qualitative data collected. And then, depending upon the project, different things would be needed to look at the progress of the research to improve the implementation. Yesterday, Rajiv was talking about the different models, that you start with the model and then you see, okay, when you are doing monitoring evaluation or quality assessment, you find that, okay, this thing is not working. So how to tweak that thing to make it better? So that can only be done most commonly through qualitative data collection, which is Sharmila is much more expert on this thing, but it is essential that the implementation research projects have this element and not only depend on the quantitative data, which is also necessary because you want to, at the end of the day, describe the descriptive and statistical analysis, etc., to evaluate the success of implementation, but through either structured observations, questionnaires, performance-based instruments, or case report form, etc., depending upon how or which design is being used for that the project. And when should the analysis happen? In most research studies, the analysis happens at the end. But here, in the implementation research, we do not want to wait till the end of the study to start the analysis, because we are looking at the implementation progress. And for that, periodic ongoing analysis of implementation is necessary. And that requires qualitative analysis to look at various aspects that are listed over here. If you leave it to the end of the study, then basically sometime you would find that this thing should have been done or could have been improved, and we were unable to do that. And that really is not something which you want. So like Rajiv was mentioning yesterday, you have a model 0, then you improve the model to model 1, and then you improve it a little further, model 2, etc., and so on. But obviously, there is always a limit to what you can do. And at the end of the day, you may have an improved model from the beginning of the study. Like, for example, when we were doing this PSBI implementation research, when we started, not many mothers were seeking care, but with time and with improvements and tweaking of the systems, the numbers started increasing, and the patient's utilization of services started increasing also. And both the workers and the parents became more confident in using the service because they had seen some things working, and where things were not working, by looking at the ongoing analysis, you could improve things. Where you found that the physicians were not using the appropriate dosages, or they were not using the case report forms, or not using the job aids, or did not have the job aids, etc. So those kind of things then can be done while you are doing these things, and to improve the interventions. And the second, obviously, end evaluation is needed to see the success of the implementation. And these basically, in all this, the researchers and the implementers need to work together to achieve this. It is not just researchers who are actually doing all this thing, because the improvement in implementation can only happen when implementers are involved fully in the system. Otherwise, then it's not basically implementation research. So in summary, I've talked a little about the context, the outcomes, study design, some analytical methods, and timing of analysis. So I'll stop here, and if there are any questions, I'd be happy to answer that.
Over. Thank you very much, Dr. Qazi, for that presentation. I know it's a very complex topic, but thank you for presenting this overview. I think for questions, Ravi from SAS had raised a hand. Ravi Shastri, you had raised a hand. Do you want to ask a question, Ravi Shastri? Unmute. Ravi Shastri, do you want to ask a question, because you had raised a hand? Okay, no problem. If you remember, you want to ask, you can ask it later. Dr. Qazi, we have a couple of more questions for you. One is, we always collect a lot of qualitative as well as even objective data in implementation research, as you also mentioned, mixed methods. So, and frequently we see that a lot of data, it's not integrated very well, the qualitative and quantitative. So what are your suggestions on how to completely use qualitative and quantitative data and then come up with single outputs from the whole studies? Your suggestions on this?
It depends upon the design and also, the studies that you're doing. And when you are planning your studies, obviously that is the time to make this linkage much more strong and robust. But if you are, sometimes what happens is that two different groups are working, and one group is not talking with the other group. One is collecting the qualitative data and other is collecting the quantitative data. And then, until unless there is dialogue going on between them, then becomes difficult, and what you're saying can happen. But if you plan it in a more organized fashion, that the qualitative data would help, the quantitative part also, so then you can have quite good results. And I think there are groups within your, participants who have done it very well. Over.
Right. Thank you. And just a related question to this. So, is it so according to you, it's a good idea to have a analytical plan written into the study protocol itself, even for implementation research studies, like we have for clinical studies?
Definitely. Without, having an analysis plan becomes difficult. But, one should make sure that you have implementation outcomes written as part of your analysis plan. And how you're going to describe the context and what kind of different activities that were done in order to get the different actors involved. So all that comes into analysis plan when you are trying to write this up. Many a times what happens is that end of the day you end up presenting more quantitative data, and the other lessons that could have been learned through implementation research projects are not really spelled out very well. So that doesn't really help others who are looking at the publications to see how they could have improved their implementation from the experience which was gathered from a group who was, implementing something in their part of the world. So it needs to actually encompass both the context, the user involvement, the qualitative issues, and also the quantitative things. But the very important things are implementation lessons that were learned, which others can then use to improve their systems.
All right.
Over.
Okay. Thank you, Dr. Qazi. If there are any more questions, please put them in the question answer box and we'll address them at the end. So Dr. Qazi, thank you very much.